So there's two types of this type of disorder. One is the hydatidform mole, or partial or complete mole pregnancy, and choriocarcinoma, which is a cancer of one of the sacs that surrounds the babies. And what this is when the egg and the sperm get together, one of them does not have a nucleus, which contains the DNA. Okay, so you're getting basically the sperm and egg come together, and really nothing comes of it because it's missing this DNA, one of them. Okay, and what happens is it starts to grow. Okay, and usually there's not a fetus there. What's growing is really the placenta's growing out of control. Okay, so that sometimes it even could be the chromosome. Sometimes it could be maybe 66, 99. It's like weird, nothing that is compatible with life. Okay. So anyway, the cause of this is unknown. Usually the management would be immediately they would do a DNC, which is that dilation and curettage, and then long-term follow-up with looking at ABCG levels. Okay. This originates in the placenta. Okay. It is made up of gestational tissue, but the pregnancy is not viable. Okay. The pathophysiology is the mole of pregnancy is classified as partial or complete. The complete mole contains no fetal tissue at all. Okay. And it develops from an empty egg, meaning there's no nucleus, which is fertilized by a sperm. The male chromosome doubles into a 46, and it's all, the chromosome material is really from the male, okay? Because the female has no nucleus in it. Okay. The embryo is not viable. The complete mole is associated with the development of choriocarcinoma, meaning that if you have a complete mole, meaning that it really is not a viable substance, you're at higher risk of developing a cancer within the uterus. Okay. The partial mole has a triploid karyotype containing 69 chromosomes, which is also not viable. All types of mole pregnancy has the risk of developing a carcinoma, which is the malignancy. Okay. Clinical manifestations, this is important to understand. It's similar to a spontaneous abortion, but it happens usually around 12 weeks gestation, 10 or 12 weeks gestation. Okay. The ultrasound will have no fetus, no heartbeat. Okay. All you'll see is what looks like a snowstorm. It's like this white material, which is part of the beginning of the placenta, and it's just overgrown white fuzzy material that you'll see on the ultrasound. Okay. Sometimes there'll be brown vaginal spotting. Okay. Sometimes they say it's grape-like vesicles. Sometimes will come out from the woman. Okay. This is just like strange kind of sensation here. The other thing is that the levels of HCG, which is that hormone of pregnancy that they test for, gonadotropin, that's the hormone, the over-the-counter test, or you go to the doctor, get a test, that's what they're looking for. So with this mole of pregnancy, you will see the HCG levels be double, triple, quadruple what it should be at that point in time. So it's an overgrowth, and HCG also is very high. Okay, unusually high levels. Okay. So this would cause the woman to have severe morning sickness. Okay, so part of we talked about hyperemesis gravidarum last week, having that morning sickness. A lot of that morning sickness has to do with HCG levels. So the higher the HCG levels, like she's carrying twins or triplets, the more likely she's going to have the morning, really bad morning sickness. Okay, so that's one of the signs. Edema is another sign. Her uterus is larger than the expected date. So let's say she's 10 weeks, and you do check to see how high her uterus is. Usually her uterus will be about maybe 20 cms, meaning at the level of the belly button. Okay, so it should be measuring 12 cms. But with this case, because it's out of control placenta growing, the uterus is a larger size than it should be. Okay. You get extremely high HCG levels. Also in this, you'll see early signs of preeclampsia, which is high blood pressure. Okay, so that is something that you will see a lot of times with these people. Usually, if you're going to see somebody with preeclampsia, you don't see it till after 20 weeks gestation. So in this case here, the HCG and the edema and the high blood pressure is something that you know, that you'll see unusual kind of things here. I have to tell you something. This story is very interesting. Let me finish this. Okay, so anyway, so you have signs and symptoms of high blood pressure. There's an absence of a fetal heart or any kind of movement. Usually no material having to do with the pregnancy, except for the out-of-control placenta growing. And you have these great, like, vesicles coming out from the woman. Okay. This is what it looks like. They're hydroptic vessels. So you can see in this case here, there's no fetus. It's just this, you know, ugly-looking bunch of grapes. But it's really, when you look on an ultrasound, it's like white. Okay. Okay. How do you diagnose this? Well, if the person has unusually high HCG level for the for what she should be in pregnancy, there's certain levels. Okay. And if they see that she has really unusually high HCG, that means that either she's carrying twins or triplets, right? Because she'll have more of that, or she will perhaps have this mold pregnancy. So they have to do an ultrasound, okay, to see what they're working with right now. Okay. So an ultrasound will show this snow-like pattern, no fetus, no heartbeat, nothing. Okay. The treatment is immediate evacuation of the uterine content as soon as possible. They will do either a dilation and suction, so they'll dilate the cervix and suction the material out, or they'll do a dilation, D&E or D&C, dilation and the curettage is a suction, okay, or E would be like scraping it out. Then the tissue is sent to the lab to determine if there's any cancer present, okay. Baseline HCG levels, they should decline and be back to normal within 8 to 12 weeks after the D&C. Okay, so she gets this material removed from her uterus, and her HCG level should go back to normal, okay, within 2 months to 3 months. They will keep a close eye on her and do a follow-up on her for you know, for the full year after she has the D&C done, okay? So the baseline HCG will be done again. They'll do chest and pelvic chest x-rays and ultrasounds, because if she did have this kind of carcinoma, it would go to her pelvic area and to her lungs. Okay. She'll have weekly HCG levels until it drops to 0 and remains that way for 3 weeks. Okay, so they want to make sure it's not going up and they miss some of it, or she's developing a cancer. Then she'll have it done monthly for 6 months, and then every 2 months for the remainder of the year. The thing to remember is to avoid the pregnancy for 1 year, okay? And why would you do that? What makes you think that you would do, why would you not get pregnant for a year? What would be confusing to you?
It's the HCG.
If she gets pregnant, what do you see in her bloodstream? HCG. Okay, you see HCG. So they don't want her to get pregnant for a full year, because they're going to be watching her HCG levels, and if they see that she's pregnant, they're going to be confused with is it the pregnancy or is she developing this carcinoma. Okay, so 1 year she avoids pregnancy. The nurse assessment, clinical manifestation, we talked about that. You're going to look at the ultrasound, the high levels of HCG. Nursing management, pre-op preparation, emotional support, education, treatment, and serial HCG monitoring. And sometimes, if they choose, they might do a prophylactic chemotherapy on the patient. We talked about hyperemesis last time. Now we're going to talk about hypertension. Hypertension is it when you're in your antepartum experience, or perhaps you'll see it somewhere along the lines in a patient's chart, even in postpartum. A lot of times you'll see it as written as PIH, which is pregnancy-induced hypertension. A lot of the doctors still use PIH to describe this gestational hypertension that can happen. Okay, so let's talk about the different categories that's in. Gestational hypertension is blood pressure that it shows an elevation of 140 over 90 or higher, and it's usually identified after the mid-pregnancy. Okay, it doesn't have protein in the urine, so you're going to see somebody at 24 weeks or something like that. So she's usually in the second and third trimester when this occurs. You'll see her blood pressure being elevated, and you will also see that when you test her urine for protein, there isn't any. Okay, so that's gestational hypertension. Chronic hypertension is somebody who had hypertension before they got pregnant. Okay, so that's somebody who actually, had it beforehand and was being treated. This is so prior to the pregnancy. Then there's transient hypertension, which is hypertension without preeclampsia. Okay. So this is at the time of birth. Usually you'll see that the person has had normal blood pressures throughout the whole pregnancy, and then when she gives birth, all of a sudden her blood pressure goes up. Okay. So chronic hypertension is the patient, or the transient rather, one is hypertension without preeclampsia at the time of birth, during labor or within 24 hours after she delivers. It usually will resolve within a 3-month period. Okay. Sometimes even earlier than that, to go back to the normal one. And then we have chronic hypertension with preeclampsia. And this is somebody who has hypertension, but now she develops protein in her urine. And she'll also have elevated liver enzymes. She might even have the thrombocytopenia. Okay. Now you'll see sometimes in the patient's chart, or you'll see that, let's say a person comes in to labor and delivery with high blood pressure, they have what we call a health panel, meaning blood work that is done to rule out this situation called HELP. Okay? And HELP stands for hemolysis, breaking down the red blood cells, elevated liver enzymes, and a low platelet count. Okay? This is usually seen in a person who has what they call severe high blood pressure or severe preeclampsia. And the results are, the only way you know they have HELP syndrome is if they have the lab work done, and the lab work comes up with what we said here, the elevated liver enzyme hemolysis and low platelet count. Okay. Nursing management would be the same as for severe preeclampsia. Okay, so gestational hypertension, the blood pressure is 140 over 90 2 times, 6 hours apart, without any proteinuria occurring. It occurs after 20 weeks, and then the blood pressure will return to normal during postpartum. Previously known as PIH, you still will see the doctors referring to it as PIH. Some really old doctors in their 80s or 90s, they'll still call it toxemia of pregnancy. That's not really heard of anymore. Okay, so we have here gestational hypertension or preeclampsia. The second leading cause of death in the United States for a woman who's pregnant. It's a very common complication of pregnancy. It may be that the person had high blood pressure beforehand, and it may be present for the first time during the pregnancy, which is a gestational hypertension. And it's classified as either preeclampsia, which is hypertension with proteinuria, okay? And usually it's also classified as mild preeclampsia or severe preeclampsia, depending, and I'll show you the list after this. The way that you know that a person has eclampsia, okay, eclampsia, the person will have a coma or a seizure. Okay, so they might have the high blood pressure and all that, and never have a coma or a seizure, so they never develop eclampsia. Okay, so both the mom and the baby are at risk when these things occur. Here is an example of mild preeclampsia versus severe preeclampsia versus eclampsia. Okay. Now we had a woman last week, I'm trying to think, it was Thursday or Friday, who had high blood pressure. Oh, wait, I'm trying to think for a second. Oh, we saw the baby, I guess it was Friday. There was a baby in the step-down unit, I believe. The mother had severe preeclampsia, and the baby was born small for gestational age. Okay, and why would that occur? If you think about it, if you think about high blood pressure, what it does is it constricts blood vessels. Okay, it causes constriction of blood vessels. Right, so that does not allow perfusion of the nourishment to the baby that usually you get from the mom. So this baby was born, what was it, 34 weeks, I believe it was, and it was small for gestational age. We plotted it on the little chart that you can plot it on. It was weighed less than it should have. The head circumference was less than it should have for that age, 34 weeks. So that was one of the side effects of this high blood pressure in pregnancy. So mild to severe, okay? We have the blood pressure greater than 140 over 90 after 20 weeks. That's mild. Proteinuria, they do a 24-hour urine. So the patient gets this big jug, plastic jug, and she has to pour the her urine into the jug for 24 hours. Put it on ice, and they'll do a 24-hour urine. And if it comes back 300 milligrams or more, that's usually going along with the mild preeclampsia. If the dipstick is greater than 1+, when you do those little dipsticks, have you all done that at all? Like for glucose or urine or anything like that? You can just dip it into the urine and wait a minute, and it changes color of this protein. Seizures, there's no seizures with the mild. Hyperreflexia, they usually will test the patella, okay, to see if the reflexes are normal or not. Usually there's no, +2 is normal for the reflexes, so usually it's +2. And then other mild edema and some weight gain. Okay. When we get into severe, okay, severe hypertension, okay, this is when the blood pressure is greater than 160 over 110. The 24-hour glucose protein is greater than 500 in 24 hours. The dipstick is about 3+ or greater of the protein. There's no seizures. Hyperreflexia is yes. So if you do the patellar reflex, it will be a little bit more significant, like a +3, which is a quicker reflex. Okay, and then other signs and symptoms of severe, it is headache, blurred vision, pulmonary edema. The platelet count is going down, sort of showing that HELLP syndrome. We talked about a low platelet count. Epigastric pain is, when a person complains of epigastric pain, a lot of times that's a symptom of the liver, okay, and the liver getting to a point that it's getting swollen, where it could actually burst. So I remember I used to, my master's in high-risk pregnancy, and I worked with a lot of people like that, and I'd be asking, do you feel any pain in your chest? Like that kind of thing. Please don't say yes. And then the essential, the cerebral disturbances, like spots before their eyes, sometimes they'll have headaches, okay? And then, as I said, the lab would be coming back with hemolysis, elevated liver enzymes, and a low platelet count, okay? Now, eclampsia gets to a whole other category here. Okay, so the blood pressure is the same as it is for the severe. There's marked proteinuria. Seizure, yes. Hyperreflexia, yes. Okay. Same as severe plus cerebral hemorrhage, renal failure. So they could die from this, going, so you're taking a step and going over the edge there with a person having a seizure. Okay. The one time I saw it was, again, when I first got out of nursing, and I worked with the high-risk pregnancy patients, and I was in charge in the evening, and this woman had delivered already. So in postpartum, you can still, in postpartum, have a seizure up to 72 hours after you deliver. Okay, after you deliver a baby, you still have that chance of having a seizure. Okay, so this woman delivered and she started to seize, and of course I called, I called the residents right away, and it was a new resident. It was like July, so we had to get the new people in, and they don't know much what they're doing. So the student, or the resident comes over. The woman has IV. He gives her like 20 milligrams of Valium IV push. Now the woman stops breathing.
Oh, shit.
Right, because he gave her too much of that. So then we have to call a code, right, on the floor. It was like, one thing after another. Also like, code on OB? What's that? You don't hear about that. And they were able to bring the woman back. But the problem was the resident gave her too much IV push of Valium. So the other thing is somebody who works all the time in L&D over in Hackensack, Virginia Crucio, I don't know if you know her. She's very nice. She said that she had a patient who came in with high blood pressure and then became totally disoriented. And it was because she was, her blood pressure was so high, and then she did have a seizure. Like, it happened like within minutes, she said. The woman was talking and everything else, and then all of a sudden she just, her mind was not right, and then she had a seizure within no time. That's how fast that can occur. That you always have to be thinking this can happen. The pathophysiology, maternal effects, again, the epigastric pain could be that the liver is getting more swollen, okay? Elevated liver enzymes, headaches, visual disturbances, blurred visions, hyperactive deep tendon reflexes, DTR, you'll see. Hyperactive meaning +3, +4. That's when they touch their knee and they hit you in the head. Decreased urinary output, increased levels of sodium, VUN, uric acid, and creatinine. There's edema and possibly pulmonary edema going on all at once. Okay. Usually the edema with the person with preeclampsia is their face gets edematous and their hands get edematous. They might have leg edema, because most people do have leg edema, probably more than 50%, especially in the summer. That's usually normal. Okay, so having ankle edema is pretty normal. It's just when you see the face having edema or the hands getting really swollen is when you see it with this type of preeclampsia. Okay, neonatal effect, we saw that on Friday, last Friday when we were in the step-down unit, and we saw that this little baby they decided to take the baby out of the mom's womb because they felt like the baby would do better outside because the baby was not being nourished because of the constriction of the blood vessels. So intrauterine growth restriction is something you'll see sometimes with the babies. An abruption of the placenta, again, that constricts the blood vessels. So again, you can see that the placenta could be pulling away from the wall. Fetal hypoxia and fetal acidosis are also possibilities. Okay. So the pathophysiology, the cause is unknown. Sometimes you see it more in younger girls who get pregnant in their teens. Sometimes you'll see it in a first pregnancy. Sometimes you'll, again, there's no real knowledge as to, there's certain people who get it more than others, meaning usually the young and the older people who are pregnant. Okay. Underlying mechanism, it's important to know, is vasospasms. Okay. You have, everything in the system, you'll see there's vasospasms going on with hypoperfusion, decreased blood flow all to the brain. That's why you have the seizure, or you have the visual problems and headaches, to the liver, to the kidneys, to the placenta. Okay, so there's decreased blood flow to all those different areas. Okay, And again, that can cause lots of problems for everybody there. So the decreased perfusion results in epigastric pain and elevated liver enzymes, headache, visual disturbances, hyperreflexia, urinary output, edema, proteinuria, pulmonary edema, and then with the fetus, it's intrauterine growth restriction, placenta abruption, or fetal hypoxia. Okay. So generalized vasospasms results in increased blood pressure and reduced blood flow to the brain, which results in the headaches and possibly the person having a seizure because of that. Okay. So we have the critical lab tests. They always do CBC. Again, on your test next week, I will also have a question having to do with CBCs, because every test so far we've had a question with CBCs on it. You always have to know that particular blood work. There's a decrease in the hematocrit and a decrease in the platelet count with this. The PTT, fibrinogen, and fibrin split is prolonged clotting time and elevation. The chemistry screen they have is an increase in the sodium, increase in the BUN, uric acids, and creatinine. Okay. Liver function test, the AST, ALT, LD, and bilirubin will be elevated. Okay. And then the 24-hour urine, you're looking for protein and creatinine elevations. Okay. So here it says endothelial injury caused platelet adherence, fibrinogen deposits, and presence of imbalances lead to increase in blood pressure and low platelet count. Okay, so there's all sorts of things that are going on all over the body with this. Okay, so medications, and for preeclampsia, you'll have to know these medications. Okay, again, some of the medications are also used for high blood pressure. People with high blood pressure in any situation, you know, Metsart and all that. Max sulfate is probably has anybody seen anybody that's been on max sulfate or heard of that? Max sulfate, magnesium sulfate. Okay. We used to have a doctor who used to put everybody on max sulfate, and we'd say, and what, I hate to say this, but he would mag them until you'd have to bag them, meaning you give them so much that they couldn't breathe anymore. The respiratory rate, so mag them till you bag them, you know. We used to call that one doctor we worked with. Anyway, so max sulfate, Presaline, Procardia, sodium, Lasix, all the stuff that you'll see. Now, I don't have any picture on my screen, so I'm going to try to show you. Just my head around here. This isn't actually right from your book. Where'd you go? Where'd you go? There you are. Ah. Right. Okay. What I wanted to do. Okay, wait a minute. Back. All right.
Damn.
Because I can't see that on my screen. So I can move upside down like this. All right, let's do it one more time. This. Stop here. Okay. So magnesium sulfate, every single test you'll ever see, NCLEX-wise, ATI, Kaplan, every single one of them will have magnesium sulfate on it. Okay, it's a drug that is used to decrease the chance of having a seizure. Okay, it's actually they also will use it in preterm labor patients, because they used to use it to slow down labor because it's sort of a muscle relaxant in a sense. But now they use it in preterm labor patients so that the baby, since they give them a little of this max sulfate, prevents the baby, when it's born, to have seizures. So it's sort of like, they'll do it also with so preterm preterm labor and also with this high blood pressure. So the big thing to know, this drug blocks the neuromuscular transmission, vasodilation, prevents and treatments of eclamptic seizures. So that's what it's used for. In reality, it is a CNS depressant. The side effect of this CNS depressant is it causes the blood pressure to go down, too. Okay? So anyway, so what do we have to know about this? They have a loading dose of about 4 to 6 grams over about 30 minutes, and then they gradually will increase the amount. You want to monitor the serum magnesium levels closely. Okay, you don't want toxicity to occur. Okay, and signs of toxicity. So monitor serum levels, assess deep tendon reflexes, and check for check for clonus of the ankle. Okay, have calcium gluconate ready and available for toxicity. Okay, so a couple things to remember about MAC sulfate. All right, it's a central nervous system depressant. It's not an antihypertensive. It does have that side effect, but it's classified as central nervous system depressant. Okay. The other thing is they have to keep an eye on the blood levels of the MAC sulfate because the patient could have toxicity from it. Okay. Some of the signs of toxicity, and this is what you have to know also with MAC sulfate, is you want to monitor signs of toxicity such as the face starts to flush, meaning a pink redness to the face. Okay. You'll see the person might be sweating. Hypotension. Okay. Cardiac and central nervous system depression. Okay. The other things that you're going to watch for with MAC sulfate is that you want to get her respiratory rate. It should remain above 10. Okay, so respiratory depression you're looking for. Her urinary output should be at least 30 mLs an hour because this can also cause the kidneys to shut down. Okay. So those are some of the things you want to make sure that those are signs of toxicity that she might have. Kidney non-functioning as well, okay, would be one of them. And there's other side effects that you're seeing is sort of, you'll see these kind of side effects of, flushing, sweating. Some people get a little out of it when they're on this medication, hypertension, and then, as I said, you have to do the urinary output, and you also do her respiratory rates to make sure that they're above 10. We have Presolin, which is a vascular smooth muscle relaxant. Again, remember we talked about the vasospasm and constriction. So this would be given to the patient, and it will improve the perfusion to the renal area, to uterus and cerebral area, and it also reduces blood pressure. They'll administer 5 to 10 milligrams slowly by the IV bolus every 20 minutes to control the blood pressure. Okay. And then they'll withdraw the drug slowly to see if it's going to cause a rebound increase in high blood pressure. You want to monitor again for side effects such as palpitations, headache, tachycardia, anorexia, nausea, vomiting, and diarrhea. So those are some of the side effects of that medication. Let me see. Okay. I think the ones they really use, they don't use that much. For cardia, we use.
The one that causes CNS depression, which one is that? MAC sulfate?
Again, this is right in your textbook, by the way. This chart. Come on, you can do it. All right. Split cardia is another type of antihypertensive drug that they can use to decrease the woman's high blood pressure. Okay, so again, the big thing also with MAC sulfate is you always have to have calcium gluconate at the side of the bed because that will counteract the toxicity. So if a person is on MAC sulfate, they always have calcium gluconate available right next to them usually, because this will, if the person starts to show signs of toxicity, this will alleviate that. Lasix is a drug that also increases the amount of urine from the woman, so maybe some of the edema will go away with that too. Okay, educate women on signs and symptoms of this. Usually, I start to do this when I work with the high-risk patients when they come into the office at about 20 weeks or so, because you don't usually see these problems until about that time. Okay, so I start to say if you notice a rapid weight gain. Let's say you're supposed to be gaining 1 pound a week at this point, and all of a sudden you gain 6 pounds. It could be, again, that edema occurring. You ask the patient if they have headaches, okay, or any dizziness. These would be signs, again, that she could be developing preeclampsia. So she would do this at home, weigh herself, have her call the office or the clinic if she has any of the other signs of headache and dizziness and blurred vision. So you want to educate the woman, and then you re-educate them as you see them. Each time you're going to ask them these type of questions, like how are you doing? Any bleeding, spotting, headache, blurred vision? Okay. MAC sulfate, all right, so here they're saying to look for toxicity, respiration less than 12. Okay, so less than 12, not 10. Okay, so you have to assess the patient hourly for her respiratory rate. She will also show signs of toxicity by absent of the deep tendon reflexes. In other words, she may not have any reflexes. Okay, she could be 0 on the reflexes because of it. Okay, decreased urinary output. Okay, less than 30 cc's in an hour. Monitor the MAG levels. Therapeutic levels are greater than 8. No, it's 4 to 7 are therapeutic levels. I was going to say 8 seems a little high. Greater than 8 is toxic, okay? And then administer calcium gluconate if MAC sulfate toxicity develops. It's an antidote for it, okay? So all that's why I'm reiterating the stuff about MAC sulfate, because you'll see it a lot. For some reason, they like to test you on that, okay? Nursing assessment, the goal is prevention of complications related to hypertension. Complete client history. Previous history of preeclampsia can also indicate that she will have preeclampsia again, so that's something to be aware of. Just like preterm labor, if a person has it once, a lot of times they'll have it another time in the pregnancy. Okay? A history, if a person has a history of chronic hypertension, diabetes, or renal disease, she's at risk for this. Extremes of age. Is a person in their teens versus a person in their 40s having a baby, okay? If she's having a baby for the first time, African American ethnicity, poor nutrition, accurate measurement of blood pressure. You have to make sure that you're taking it, not over her clothes, but on her arm, okay? On her skin, not her clothes. Assess for headaches, blurred vision, epigastric pain. The presence of edema, check for her deep tendon reflexes. What I used to do in the hospital when we had patients like this, I never could find a reflex hammer, right? So I take the body cream lotion kind of thing bottle, plastic bottle, and I smack her on the leg with the patella, and she'd give the reflexes. It works, even your hand can work. You don't have to have a reflex hammer, but just to look for that. Urine dipstick for protein. Again, the fetal well-being of the baby, needing non-stress tests and biophysical profiles. Okay, will be done. Again, testing to see that the baby's growing, the ultrasounds, to see that the baby's not growing. Okay, and lab values, like the health values and CBC. So those are some of the things that you have to do. Okay, stabilize mother and fetus and prepare for birth. is usually what they'll do. Depending on how far they are into the pregnancy, again, like that baby that was not growing in utero, they felt as though the lungs were mature enough, or they might have done that amniocentesis. They can do amniocentesis in the last trimester to see if there's lung maturity. And if they see the lungs are mature and the mom's blood pressure is going up and the baby is not growing, they're going to get the baby out. Okay. So mild preeclampsia, how they can manage this, okay, is they can have a person go home, okay. Sometimes they have a home health visiting nurse come to them and visit them, okay, at home. So if it's mild, manage at home if no signs of renal or liver dysfunction. Bed rest, lateral, so she should be laying on her side. Daily blood pressures, daily weights, urine dipstick for protein, and fetal kick count. Okay, so this is something the patient can do. You can buy those blood pressure cuffs that are really, really easy to use. You know, they're starting to teach them how to do blood pressure at home. Okay, and then fetal kick count again to make sure the baby is moving continuously, not constantly, but on a regular basis. With severe preeclampsia, monitoring closely for eclampsia. Max sulfate therapy, have calcium gluconate available for toxicity. You would be monitoring for blood pressure, for dependent reflexes. They will have her in a quiet room, bed rest, continuous electronic fetal monitoring, lab tests, ultrasound, and seizure precautions. Okay. So usually when we have a woman like this, a severe preeclamptic patient, we would usually even keep the shades down. And keep the room quiet just so that she's, relaxed atmosphere so she doesn't go and have a seizure, okay? So we try to limit the amount of visitors, okay? Also would be something we'd be doing, okay? This one is, okay, so we have that already, okay. Okay, eclampsia, this is an emergency, okay, it's life-threatening. Again, this is when a woman goes into a coma or has a seizure. That is the definition of eclampsia. All right, that might be a test question. How many people do we get it wrong? Always take a bet on that, right? How many people get that wrong? Okay. So eclampsia has all the signs of severe preeclampsia, but the difference is what? Seizure. Oh, right, exactly. You'll get it right. Other people in that order. On their Twitter accounts already. Okay, so life-threatening. Clear the airway, administer O2, protect from injury, IV access, electronic fetal monitoring, and again, that mag sulfate will be given because it's a CNS depressant, okay? And then stabilize the patient and then deliver the baby, okay? Okay, this will really go up. Did we do this already? I can't remember if we did twins already. You're going to see more and more people with twins or triplets because of a lot of women getting pregnant when they're older. They do in vitro fertilization, and a lot of times they have, what happens is they will ovulate more than one egg, okay? Or even like they'll do a transplant where they'll have the egg and sperm in like a petri dish, which together they will fertilize a bunch of fertilized eggs. They'll freeze them if they don't use them all. But they might put 4 eggs into a woman's uterus thinking she's lucky if 2 survive, Some people get 4 eggs and they get 4 kids. So it's just a matter of, what's going on with her and her hormones and stuff. So anyway, so more than one fetus. The fetal risk would be respiratory distress because usually they're born earlier than singletons. Birth asphyxia, congenital anomalies, twin-to-twin transfusion. Twin-to-twin transfusion is usually you'll see that one baby's 7 pounds and the other one is 4 pounds. So that at one twin is getting more nourishment than the other one. Okay, so sometimes you'll see that. And intrauterine growth restriction and conjoined twins, which are the Siamese twins. Okay, see the picture of that. The types of twinnings are monozygotic, which means one zygote, mono, right? Mono is one, zygote. So that zygote and sperm, the zygote is the fertilized egg, will split in half, okay? And that will be, they have the same DNA material, okay? So the twins who are monozygotic will have the same DNA, okay? Fraternal twins, you see a lot of those because of the in vitro, so they will not have the same genetic material. They will be like a brother and sister, or two sisters, they're not going to be identical, okay? So that's the difference between the two. Usually what they'll do is serial ultrasounds to see, meaning they want to see the babies are growing evenly, okay? Biophysical profiles, possible hospitalization if they are possibly getting preterm labor or something happens to premature rupture of membranes. You want to assess the uterine size, monitor for the both fetal hearts, and assess for hemorrhage after delivery because her uterus has been stretched out so much that she could have a post-parole hemorrhage. Okay, here we're going into preterm labor. Okay, I was 2 o'clock. It's 2 o'clock. Okay, preterm labor. I'll give you a break after this. Now again, these pages are from the first. The last, not the newest textbook, the one before that. So you can just look under preterm labor and you'll find preterm labor someplace in this book. Okay, preterm labor occurs. Regular uterine contractions the woman will feel, resulting in cervical effacement and dilation before the end of the 37th week. So again, meaning that before the end of the 37th, if she's 37 weeks, it's preterm. Okay, so preterm labor. If it's not stopped, the preterm labor, you'll get a preterm birth. Okay, leading cause of perinatal morbidity and mortality worldwide. 12% of births. 1 in 8 infants are premature, okay? So again, look at how tiny that little baby looks in that person's hands, you know, really, it's amazing. But preterm labor, you do see, how many people have seen anybody who was hospitalized for that? Anybody yet? Yeah. Probably this week, next week, we'll see more people. Yeah, preterm labor can occur. We had that lady, let's see, Thursday's group. The 2 women, there were 2 women, I think, I don't know if it's the ones on the regular floor, I think 10 and 11, 10 and 11. There was a woman there who was in the hospital for 2 months because of an insertion of the umbilical cord was not correctly inserted into the placenta. Do you remember what that was? She was explaining a little bit to you. And she was 34 weeks, and she was laboring. Remember, she was contracting, and they gave her medication to try to stop the contractions. But at that point, they were going to do a C-section on her on the weekend anyway. So this was Thursday, so they did a C-section on her and delivered the baby. And she had a little boy, right? And the baby, I think because he was 34 weeks, went into the NICU, and then he had respiratory arrest. But they intubated him. So when I came back on Friday, he was intubated. And the mother was coming in there with, the husband was sort of like, I don't know. Everybody thinks he's going to do okay. The baby was sort of scared to see that, But anyway, back to this. So you can see preterm labor. Do you see the signs up in the hospital on the maternity floor saying like 40 weeks? There's like a whole kind of push for women to have their babies at, 40 weeks or so, around 39, 40, 41 weeks. A lot of people will try to convince their doctors, oh, I'm tired of being pregnant. We had a pediatrician one time come in saying, I just want this baby out. She was 37 weeks. I've had it when pregnant. And, I don't know if it was a first, I hope not. But what they're trying to push for is that they're seeing that babies that are born before the end of 37 weeks will have these respiratory distress problems, more likely, So they're pushing for people not to go and, deliver before they really should deliver the baby. Okay, so that's a problem sometimes with patients and doctors. Preterm labor, okay, so cause is usually unknown. accounts for 75% of all neurodevelopment disorders, okay, meaning that they're born too early and the brain hasn't developed well enough, and then you have a bleed into the brain. $30 billion a year maternal and infant care related to prematurity. These are the kids, a lot of times with the brain disorders, end up at that children's hospital down in Robert Wood Johnson. They're basically not really high functioning. That's a problem there. Okay? And then they, it's a hard situation all the way around. How many of you guys have gotten to your NICU? Have people get to NICU yet? Okay. So you see some of those. You see some of the tiny, tiny little babies that are born. It's just amazing. You really have to see how, they really are at risk for all sorts of problems. Okay, preterm infants at risk are what the risk for of respiratory distress, infection. They might have heart defects, obviously thermal regulation because they don't have any fat on their body. Intraventricular hemorrhage, they look for that. That's one of the worst things that can happen because they become developmentally have a developmental disorder. Feeding difficulties and behavior, social problems. Okay. So again, there's a lot to be said. I can't even say. We're saying to some students, it's like hospitals always want to tell you, we had so many babies, born and survived that are preterm. But then I always wonder, what's the quality of life? You know what I'm saying? So they survive, but they may not be neurologically. They might have to go to a children's hospital for the rest of their life, or whatever, nursing home. So a lot of times it's a hard call for some of these doctors to, the baby comes out breathing and they do everything they can to help, but it's no guarantee that the baby will make it and be well. Last year, I think it was this semester last year, we had this, right in the beginning of the semester, we had this baby that was born at 500 grams. That's just viability. That's the definition of 500 grams or more as a viable fetus. And every week we'd go back and check on the baby and check. The baby was growing. Had no problems. By the end of the semester, the baby was like a couple of pounds or whatever, and no bleeds into the brain, no respiratory problems. So that was a rare event, but it was interesting. We'd go back and look at this baby every week to see how it was doing. And sometimes they do well, sometimes they have setbacks. So, that's something. I would hate to be a parent having to deal with that, I have to say. It seems like it would be an overwhelming experience. And you'll see the nurses in the NICU are very, very compassionate. You have to be. Okay, so therapeutic management, the goal is prevention. The American College of Obstetrics and Gynecology recommendations consider probability of labor, gestational age, and risk of treatment. So it really depends on when the woman goes into labor, what they'll do. I had a student, I had a couple of students. I had one student whose wife had a mole pregnancy back 10 years ago, and had to have the D&C done. And then she accidentally got pregnant 6 months later, and the doctors were not thrilled, and she had to end up aborting the pregnancy because they couldn't tell if it was a carcinoma or not. Another student of mine, again, probably like 8 years ago or whatever, right at the end of the semester, she was probably like in her late 20s, end of the semester, she got pregnant, and she came into my office, I'm pregnant. I was like, well, congratulations, she was going to graduate and all that. And so then I was at, I think, Inglewood Hospital or Bowling Green, one of those. They always blend into each other. With students one semester I was there, and I see on the board in labor and delivery this student's name. I knew she wasn't due. She had just told me she was pregnant like a few months before. And I see her name, and I knock on the door, go in there, and she was 20 weeks pregnant. And she was contracting. And actually, she had come to my office I was teaching at summer school, and she goes, I feel like this little cramps or, crampy pants. I said, go to your doctor. Don't ask me. Just go to your doctor with those complaints, And it turned out she was in premature labor, okay? And what happens is they put you on medication to try to stop the labor, doing all these things, but she kept contracting. And the doctors came in, I think she got to 21 weeks or something. The doctors came in and said, well, you know, if the baby's born, I think maybe 22 weeks, sort of borderline. The baby's born, do you want us to do all it takes to keep the baby alive, you know? And she said no, because that, at 22 weeks, you can do so much for the baby, but really, a lot of times they just don't make it, or they end up neurologically damaged, you know? So really, viability is really like around 24 weeks, so she was like 2 weeks behind that. And her decision was to just let it go, you know, and that was a hard decision. And it turns out, a few years later, some student, I don't know why or where, turns out she's a labor and delivery room nurse now, okay? And she actually ended up having a viable, normal baby after that incident. But those are these decisions, you know, these borderline kind of things that, you know, do you want to do everything you can and not be guaranteed? You're never guaranteed of anything, but it's less guaranteed, you know, less guaranteed of a healthy baby when it's 22 weeks. But anyway, okay, so preterm labor. Let's see, consider the probability. Okay, so you have to see what gestational age the person is, the baby is, risk of treatment, no clear first-line tocolytic drug. So a tocolytic, you know how the monitor for the ultrasound, for the, when you're in the fetal monitor, you have the toco monitor, which is for the uterus, and then the fetal heart rate monitor. Okay, so the toco monitors for the uterus. So a tocolytic has to do with the uterus, and a tocolytic drug tries to quiet the uterus, meaning stop the contraction. So that's how they're labeled tocolytic drugs. Okay, they promote uterine relaxation. Entire clinical picture and healthcare provider preference dictates the treatment. Some will use antibiotics. One of the things they find that if a woman is going into preterm labor, they will do a urine test to see if she has a UTI. Believe it or not, having a UTI puts her at risk for going into preterm labor. So they'll check her urine, and they'll check to see if she has bacteria, and they'll treat her UTI. And sometimes the preterm labor goes away. Okay. Steroids are used to improve fetal lung maturity between 24 and 34 weeks gestation. We had a couple of patients in high risk last week who were early, like 26 weeks or 30 weeks or 34 weeks or whatever, 33 weeks, and they all get something called betamethasone. Okay, betamethasone is the steroid they use to give the mother, usually 2 shots, like 12 to 24 hours apart, one time, 12 to 24 hours later. And what this does, it stresses the betamethasone will stress the baby's lungs, so the baby's lungs will develop a little bit faster. So all the women we talked to who were there in the hospital all had their betamethasone, so that if the baby was delivered, then the lungs would be a little bit more mature. Okay, so that's something that they'll do for a woman who is premature labor or premature rupture of the membranes, anything like that. Okay, tocolytic therapy, prior use must consider risk of tocolytic medication, extent of cervical dilation. Sometimes they won't give it to the woman if she's 3 centimeters or greater. It doesn't work. Okay, so they may not give her the tocolytic. The membrane status, are they ruptured or not? Gestational age, presence of infection. Usually ordered by if preterm labor occurs prior to 34 weeks. Does not prevent preterm labor, it just delays it. Okay, so a person gets this drug to stop the contractions, but it delays, you know, so it might work for like 3 days, 4 days, but it allows that betamethasone to get on board to stress the baby's lungs. Okay, so they're stopping her from, you know, contracting for a few days, but it gives them time to get that betamethasone shot to the mom twice, and it stresses the baby's lungs. Okay, so it buys time to reduce fetal respiratory distress. Okay. Tocolytic medication. INMT. It's not my time. Oh, that's what it is. It's not my time. Okay. INMT. It's not my time. Okay. Okay. So What they'll do is tocolytic medication, max sulfate, which relaxes the uterine muscles, but they're not using it as much for preterm labor anymore, but they're using it so that they found there was some kind of study that was done showing just having max sulfate on board for a few hours or whatever reduces the risk of the fetus or the newborn to have seizures. So now they're just using it to prevent seizures or neurological problems in the preterm baby. Okay. Tributaline, they will use something called tributaline. It's also referred to as breathine. Okay, and breathine originally is for asthma, but it has a secondary use for stopping the contractions. Indocin is a prostaglandin inhibitor. Prostaglandin, I've said before, causes cramping and contractions. So this will, Indocin will reverse that prostaglandin, so the woman will contract. Procardia is a calcium channel blocker. Again, they will use this. You'll see more or less nowadays that you'll see a lot of Procardia being used. Not as much tributaline. I have to ask about the Indocin, but I know Procardia seems to be the drug of choice that they seem to keep using on patients with preterm labor. Okay. These drugs are off-label, not FDA approved for preterm labor, and they do have serious side effects, and they require supervision. This is the story I talked about. Prevents or reduces severity of respiratory distress syndrome. Administered 24 to 34 weeks. Requires 24 hours to become effective. So the tocolytic will buy the time to give that baby this chance the lungs to develop or get a little stress from the medication. So it takes 24 hours for this drug to actually work on baby's lungs. Okay. Diagnostics testing for preterm labor. There's a couple of things that they can do to predict, perhaps, that the woman may go into preterm labor. Okay, there is a protein that is produced by the cervix, okay, and this protein is fetal fibronectin, is what it's called, fetal fibronectin. And what they'll do is they'll go to the cervix, okay, and get a little swab there, and then test to see if this fetal fibronectin is present in the cervical area. Negative results means that 98% chance client will not deliver in 1 to 2 weeks. So if there's nothing there, it's pretty accurate to say that she's not going to go into labor or deliver in the next couple of weeks. Positive results have a chance of delivering early, but not necessary. So it's more, if you get a negative result, you're pretty consistent with the fact that you probably will not deliver the baby. If you get a positive result, it can be iffy. So it's not the greatest result. You want to sort of get the negative. Test results are not used alone in treatment of preterm labor. Okay. So depending on the whole picture, and then cervical dilation, how the person's laboring. Okay. Also, they can do a transvaginal ultrasound. It measures the cervical length and width. Okay. Again, if the cervix is short, the woman's at risk for preterm labor. Okay, she has a short cervix. Okay. They will look to see if there's fundling, they call it, width and length, percentage of fundling, sort of like pulling into like a funnel, like going into itself. Again, that could put the person at risk for preterm labor if they have that in their cervix. Measurement of closed portion of the cervix is most reliable. Cervical length that is less than 3 cms, delivery is unlikely. It's unlikely for 2 weeks, I guess is what I'm saying there. So, doesn't make sense. Should be the other way around. All right, so I guess if she's less than, no, I don't think that's right. I think if she's less than 3 cms, the delivery is likely in 2 weeks, because that's a short cervix. Okay, preterm labor nursing assessment, know your risk factors. Again, history of prior preterm labor, African American, low socioeconomic status, alcohol, drug use, hypertension or PIH, preterm premature rupture of membranes, infections such as STIs, multiple gestation, which means twins or triplets, pre-existing diabetes, and incontinent or insufficient cervix. Symptoms are subtle, okay? They're very subtle. There could be a change or increase in her vaginal discharge, okay? So that could be a change for her. Low pelvic pain, low, dull backache, okay? That's one of the big signs there. They think it's just a backache, but it's actually like a, sort of like a feeling that doesn't go away. It's a dull pain. Aching in the thighs, okay? Uterine contractions may not be felt by the client. Again, it could be that backache coming and going. It could be a sign of preterm labor. Cervical change will take place if basement and dilation will occur. Okay. And then know your meds. Okay. Administering tocolytic therapy, contraindications, infections, fetal distress. So these are things that you wouldn't give the woman tocolytic drugs if there's an infection there. There's fetal distress, vaginal bleeding, or fetal demise. Know the side effects, monitor vital signs and I&O, lateral positions, psychological support, educate clients about preterm labor prevention, signs and symptoms of preterm labor, and how important it is to hydrate yourself. Okay. Med side effects, hypotension, nausea, vomiting, cardiopulmonary arrest, MAG toxicity, tachycardia, all that. Okay, so everybody take a break. Stand up, stretch.